It is a patient and provider decision based on their capability to take warfarin or not. However, we have published probably the most significant paper in the Journal of American College of Cardiology, or JACC, recently, that analyzed many patients, over 100,000, to take a look at the threshold of benefit between mechanical and biologic prostheses. What we looked at, longitudinal survival, and that threshold began at age 65, which is where the odds ratio crossed unity of not just morbidity, but survival. But at age 60, the upper bounds of the confidence limit was very clear. The patients age 60 and lower would very clearly benefit in terms of long-term survival from a mechanical prosthesis. Now, the final decision is obviously tailored based on the patient and the provider, the physician. And that relationship is sacrosanct, and you have to make that decision, or your viewers make that decision on what they feel is the best for the patient. If a tissue valve is, as long as they understand that that will likely degenerate and will require a reoperation in time, then that's up to them. Mechanical prostheses, particularly some of the more contemporary ones, are very durable and long-lasting, and may be the only operation they'll ever need, albeit they will need to be on lifelong Coumadin, but perhaps at a low dose if the appropriate prosthesis is selected. And then finally is the approach that in my hands and in my institution, this patient would very likely, after all of this conversation, would receive a robotic-assisted small incision on the right side of the chest, not on the anterior chest, aortic valve replacement with a mechanical prosthesis would be my recommendation.
So, in your experience, two follow-up questions. One, how would you address the argument he's a physician, says that he has no symptoms? And two, what did you, in your experience, see was the benefit of the robotic replacement compared to sternotomy in how patients recover?
Sure. So first, if this patient is a physician, I have no concerns of mechanical prostheses since they would be very compliant with their medications. They would track that. They could use the home INR kit after 3 months, and they would have full access to the facility and medical care to assure their compliance within range and mitigation of complications of oral anticoagulation.